I think there's a whole series of buttonhole, and because not too many people have buttonholes as of now, so that is why I just put it all together. And there can be many problems, but notice that the buttonhole flap is only 0.2 to 0.56%. It is even much lesser. This is, in fact, an older data. And if you see a newer paper, you would see that there's hardly any buttonhole flap, although people have reported buttonholes even with a femtosecond laser. But if you look at the numbers, they are going down. All the complications, in fact, are going down, and it can be superficial or it can be deep. And this is a classical buttonhole, a horseshoe kind of a tear which is there. Epithelium at the superficial, it is going to be involving the epithelium and the Bowman's membrane complex, and when it is deep, it involves the full thickness. These are theoretically the possible mechanisms. You can have it in steep and flat corneas. Steep cornea because of central buckling, flat cornea because less tissue is exposed, deep orbit, conjunctival chemosis, inadequate suction ring placement because of poor suction, uh, lack of synchronization between translational keratome movement and oscillatory blade movement, and also because of damaged blade. So generally, classically, what is done is that we defer surgery and perform a recut after 3 months. But there are people who are proponents of an early PRK or surface procedure, because that would cause less subepithelial fibrosis and possibly take care of irregular astigmatism. And some people like to do it late because of refractive stability, and that can be a point of discussion. Now, this is just to show that people have done one-step transepithelial PRK with mitomycin C as an early treatment for LASIK flap buttonhole formation. And this is a spree of buttonhole flaps which we had at our center because of damaged blades almost about 18 years ago, when we started with the microkeratome present right in the center. The thing which really stands by you is the peripheral marks which are present, with which you can, align these buttonholes, and which you can align the flap later on. This is a case of post PK LASIK which is being done. And here the shape is a little different. It is kind of Z shape because of a steep cornea and astigmatism. Now, the potential for these buttonhole is two. One is that they will increase the chances of DLK. There will be a chance that there could be epithelial ingrowth. There could be a chance that there can be infection. So one of this is a epithelial ingrowth here, and we did do a PRK for this case early because we wanted to take care of the both the things, epithelial ingrowth, which occurred in fact very quickly, almost immediately, within a couple of weeks. And because the refractive error allows you, you can possibly do this. Of course, these have to be prevented by checking the intraocular pressure. If you're using the microkeratome, avoiding pseudo suction, using deeper cuts for steep corneas, larger suction rings for flat corneas, always inspecting the blade under the microscope. And if there are previous keratotomy incisions, then one has to be a little careful. And of course, you have to prevent microkeratome jamming, suction loss, and the drapes, lashes, loose epithelium should not be there in the suction ring. And of course, precipitated salt of irrigating solution should not be there. So whenever you have a tear in the flap, which is peripheral, then you can still proceed with the ablation after protecting the hinge. But if it is mid-peripheral or central, then you have to reposit the flap back and recut at a larger depth and at a area which is, and use a suction ring which is uh, bigger than the previous one. This is present right in the periphery, so one can still ablate. And in the post-op period, one has to be careful that there is no DLK, and also careful that there is no epithelial ingrowth through the edge of the tear that happens. Now, whenever there's irregular astigmatism due to the buttonhole, people have used transepithelial PTK for that. And this sort of an option is available with the Schwinn machine, which takes care of the irregular astigmatism. Another thing which can happen in a buttonhole flap is that you can have infection, such as here, which was referred to, this case was referred to us. And in this case, we did do the scrape. But when you have a flap which is so edematous, then you almost invariably have to amputate it, which was done in this case, and the organism was Staph aureus. Of course, the patient will lose their best corrected visual acuity in this eye because of infection. And this was a study which we did at that point in time to see what happens to the outcomes as far as the visual acuity is concerned. Of course, here the quality of the vision possibly was not studied, only quantitatively it was studied. And if you see quantitatively for all the flap complications that have occurred in 15 patients, 15 eyes, the results were not different, provided you do manage them in the correct manner. So the immediate approach for a buttonhole flap is carefully clean the stromal bed, ensure good alignment between the flap, buttonhole, and uncut tissue to prevent epithelial ingrowth. Conventionally, people like to abort the procedure, and one can defer the retreatment to at least 12 weeks. And LASIK can be done with a deeper flap cut. Alternatively, transepithelial PRK followed by mitomycin C can be done. And for irregular astigmatism that is there due to the buttonhole flap, a PTK can also be done, provided you have this laser which addresses the irregular astigmatism and causes the regularization of the surface. Thank you very much for your kind attention.
Thank you, ma'am. That was